Right. First and foremost, thank you for your patience. Hopefully, this will be the last week that we'll have any true difficulties. However, to help keep things going steady, I wanted to provide this video lecture for you. It is covering chapter 2, where we'll be talking about multicultural counseling and therapy. First, let me say we're not going to go through the entire chapter. I'm going to discuss some key points and start the presentation off with that information that's pertinent for you to understand in terms of multicultural counseling. However, I'm going to rely on you to do the reading of the chapter and write down any type of questions you might have. Now, toward the end, I'll talk about an assignment that will be submitted this week along with your regular assignment. And this is more of, again, a reflection paper format. For Dr. Romero, I'm going to keep putting him off until we're actually in class together, I guess. But I did want to provide you with something to work with that reflects this chapter. So, with that being said, let me go over the objectives of Chapter 2 so you have an understanding of what you'll be reading. And it's going to be looking at the clinical practices as well as how we might respond culturally to counseling or therapy. We'll look at what the meaning of etic and emic is within multicultural counseling, as well as talking about competence in multiculturalism. We'll look at the Eurocentric assumptions that happens in clinical practice, as well as some of the different characteristics that leads to the 3 levels of personality identity when we're talking about culture. Last but not least, on this slide, we'll look at those differences in terms of how we would be counseling diverse clients culturally. Other topics you'll find in this chapter will be ways we might constitute the distinctions that you'll find within various cultural groups. We'll look again at the different modalities that's found within therapy and multicultural counseling in terms of cultural competence, and then those distinguished features that's a part of competence and humility. Now, I have a separate, whole lovely different type of presentation that I presented at CEPA just this past April in terms of talking about cultural competence and the differences and the distinguishing markers for cultural humility. So somewhere along our semester, we'll get into that as well. Probably won't be today, though.
This section examines the role of race and culture in everyday life and how counselors approach therapy in a culturally sensitive manner. We begin by defining and understanding the concepts of etic and emic. According to Sue and colleagues, frame etic as the culture universal perspective, a kind of outsider's view that looks for patterns or truths that apply across cultural contexts. In contrast, emic is the culture-specific perspective, centered on the insider's own cultural meanings, values, and practices. Etic formulation's definition, concerned with commonalities among human beings regardless of cultural background, stays above the fray, seeking generalizable principles. Examining this helps us identify universal psychological dynamics or counseling strategies that may be applicable across cultures, provided we're not force-fitting them in a colonial manner. Emic formulation, starting with the definition, laser focused on what is uniquely meaningful within a specific cultural group, how insiders interpret symptoms, distress, or healing. This matters because it is vital for tailoring counseling to be authentic, respectful, and effective, rooted in the client's very worldview. An example of etic can be found within attachment theory, the basic idea that infants form bonds with caregivers for survival, gets considered a universal etic framework in counseling, yet how attachment is expressed or valued might vary culturally. Still, the theory's scaffolding is an etic scaffold. not directly from Sue, but a typical illustrative example, useful for questioning your assumptions. The emic example, according to Sue's worldview, consider culturally specific syndromes or behaviors, say ataque de nervios in some Latinx communities, a culturally bound syndrome involving intense emotional expression, screaming, trembling. It doesn't always match DSM categories, so it's an emic phenomenon. Sue emphasizes that good counselors need to lean into these insiders' meanings. Okay, so to further explain, let me use myself in the process. We will look at this in the lens of Teresa, the insightful writer, psychologist, artist. This as having research being reflexive. If I am looking at it through an etic lens, I may try to compare the various coping mechanisms across cultures, seeking general patterns that may be helpful in the broader context. Using an emic lens, I would probably instead weave in how a specific community frames healing as the center stage, viewing their own symbols and stories, and how to incorporate such perspectives. Now, besides those viewpoints, we have clinical humility. Edit gives you tools that might fly. The emic forces you to ask, does this even make sense to them, and invites deep listening. Oversimplification. Only using an etic lens can flatten the canvas, missing how people uniquely color their experiences. Going too emic can trap you in cultural specificity without finding points of connection or broader psychological truths. It's a balancing act. Now, bringing this all together, we should question the dominance of etic frameworks. Are they resilient truths or just comfy generalizations? Sweet talk every client's worldview. Ask, what does this mean to you? Emic nudges. Let your skeptic self challenge. If it's truly universal, could it erase differences? If it's too niche, can we ever connect?
All right, so now we're going to continue talking about race and culture matters. And we're going to delve into those cultural concepts of distress. Now, Sue and company, pretty much they highlight how clinicians, they really need to be able to recognize culture-bound syndromes. That being those clusters of symptoms that would deeply be meaningful within a specific culture, but not always matching what Western diagnostic norms would be. For instance, ataque de nervios among Latinx populations would include tears, heat in the chest, depersonalization. Um, there may be some emotional intensity, but yet it's not merely a translated form of what the DSM considers to be a panic attack, but it do reflect deeper cultural context as well as meaning. So if we overlook these type of risks, misdiagnosis and ineffective treatment will be evident. Secondly, we need to really take a look at and acknowledge group differences. So an example to kind of help us follow this thought process is about Dr. D. Dr. D, he's a Eurocentric trained counselor. Now, with Dr. D, he has brushed off cultural distinctions by saying, well, we're all human. We're all the same under the skin. And the list goes on. However, he's working with Gabriella, and Gabriella is a Latina. Uh, and when he says this to her, she freezes. And this definitely shows that she's not feeling comfortable with what he said. Here, Sue warns us that if we dismiss one's cultural identity, even with well meaning universal statements, we can create a therapeutic rupture. As you may have recalled, or those who have taken me in the past, one of the strongest components I always talk about in therapy is being able to establish a rapport as well as maintain a therapeutic alliance. Now, part of that process includes being able to recognize as well as validate group specific experiences that are essential for building trust. If a therapist inadvertently negates a person's cultural identity, what is that called? Yeah, this falls under the guise of microaggressions. Specifically, it's a micro insult. He may not have meant it, it's inadvertent, but it still has occurred, and it's impacted Gabriella. Additionally, we must also be aware of the viewpoints and belief systems of those who gravitate toward collectivistic cultures. So now let me go back to that example with Dr. D. Again, there's that individualistic bias that he's pushing, and he's trying to push it onto Gabriella. What he's doing is he's attempting to convince her that she needs to move toward autonomy. That being, you have to look at what you want, Gabriella, not what your parents want. You don't need their approval. However, are any cues being ignored, or are being unseen by Dr. D? Now we can say this is considered to be a cue culture jam. Because in many collectivistic cultures, particularly in this case, in this example of Latinx, as well as Asian traditions, interdependence, family harmony, communal obligations, is not considered pathology. They're prized values. So if we're imposing Western norms, risk, alienation, and even cultural oppression, if we just totally negate their instance of family relationships. Now, I'm going to say this. For those who have worked with me already in the ethics course, I probably have told you and shared this story in one fashion or another. But working in Alaska, working with the Yupik culture, that is a collectivistic community, and I've shared some of the fun instances I've had with trying to learn about that culture and some of the pitfalls that I myself put myself in, as well as having to help other cultures understand me in the process. But anyway, that's not what I wanted to talk about. What I did want to talk about is there was a case that I was working with, individual, married woman having marital issues, and her difficulties in trying to handle this revolved all around her not looking at herself at all in terms of responsibility and accountability, but relying on family to try to guide her and tell her what to do. So I had to tread carefully because I needed this client, let's just call her Jane. I needed Jane to kind of see herself so that she could gain insight that although her family is her support system, although her family helps her get through everyday situations, that she still has to kind of be accountable for her own actions and how her behaviors impacting other family members, or in this case, her spouse. And that was a real balancing act because she has this collectivistic viewpoint in which she would go to her mom or go to the grandmothers or elders in that fashion and get their thoughts and their opinions on how to handle it. But she never gives them 100% clear picture of what's going on. So it was where I actually had to have her take on a more Eurocentric point of view for a moment to help gain insight that in order to utilize her support systems effectively, she has to be, fully honest and disclose everything to them. Not giving them cookie cutter or piece things, thinking that, well, if they don't hear the bad parts, then they'll always see me as good. She needed to know that she has to talk about herself in the totality. But it was within this instance that I had to express her being a little selfish. in more than one way, in how she's dealing with her family and how she's seeing herself, um, and not giving of herself to the situation, that she felt that she had to really encompass everything that the family was providing, but because of that, it's not allowing her to be responsible. So in that case, that's where we had to kind of work, but I had to tread carefully because I did not want her to lose sight or to feel any type of devalue of her family connection, and the fact that it's her family that's a part of her identity. So I just wanted to bring that up because it's easy for us to lose sight, and we start throwing our own worldviews in there, and you have to be extremely careful to recognize when and where and how you're using your own situations in life. So Sue and them, or Atal, they kind of urge us to really try to make sure we respect collectivistic realities and then adapt that therapeutic models that we are utilizing within those theoretical orientations frameworks. Make sure we're using it accordingly. So one answer for clinicians that we have to be is attuned to those cultures as well as the clinical clues that's presented. Sue often invited different clinicians to take part in being a detective, so to speak, to kind of help us in terms of cultural anthropology. Here, what he suggests is that therapists would really need to stop and listen beyond the symptomology. Look what's behind the phrase of ataque nervoso. Why did, for example, Jennifer Lopez, why would her song spark any kind of conflict when she used the term fetish? Is that revealing about a family dynamic or a cultural meaning? These are questions and cultural clues that helps to reveal underlying norms, values, as well as context that's going to be crucial or effective, as well as respective in therapy. Now, in addition to that, we have to, like I said, balance. As a clinician working with clients, it's always about balancing what we understand and within our competence, and looking at the culture specific as well as cultural universal orientations. So in this segment, I'll say this. Sue talks about how we need to be between Schuyler and Charbis. I'm probably mispronouncing those, but looking at one side, ITIC is that universal, the culture universal, and again, that approach. For example, panic disorders that may appear in the cross-cultural, uh, across cultures, excuse me, is going to look one way, and then you have on the other side of it the EMIC, which is culture specific. We might recognize that as the attack of the nervosa, or that it has its own logic and meaning within the Latinx context. So when we're taking a look at this, the key point is integration. We don't want to disregard universal phenomena. No, I'm not saying we do that, but we also will not flatten any type of cultural nuances. When I say balance, it's trying to take it and blend both so that we avoid any type of cultural blind spots or any kind of overgeneralizations. So that's certain things that you want to keep in mind when we're talking about race, culture, and matters. These 5 different areas are extremely important for us to consider when we're working with clients.
Good clinical practice would include the skill set of cultural competence, Clinical competence isn't just about knowing your DSM or mastering CBT techniques. Sue argues that cultural competence is not an add-on skill. It's part of what makes counseling good counseling. Think of cultural competence as the foundation. Without it, even evidence-based interventions risk misfiring. Example: teaching assertiveness skills to a client from a collectivistic background without considering family harmony may actually undermine rather than enhance their well-being. Know that cultural competence is higher ranked to counseling competence. Here's the hierarchy. You can't be clinically competent if you're not culturally competent. Cultural competence is the umbrella skill. Counseling techniques are the tools underneath it. A counselor who knows CBT but ignores cultural context may technically deliver an intervention, but ethically, they've missed the mark. Sue reframes counseling competence as incomplete unless it's nested within cultural competence. As clinicians, we must realize that therapeutic bias may cause cultural errors that will affect treatment. Bias creeps in subtly, assuming quiet equals depressed, or family obligation equals codependence. These biases distort assessment and intervention. Sue refers to them as cultural errors. Example: a therapist might misinterpret a Native American client's silence as resistance, when in fact it reflects a cultural value of respect and listening. When we define counseling or psychotherapy, it is with the realization that the definitions are culture bound. Western counseling tends to emphasize individuality, insight, and verbal processing. However, be aware that these definitions are culturally constructed. Other cultures may value healing through community rituals, spirituality, storytelling, or nonverbal practices. When we universalize Western therapy norms, we risk invalidating other pathways to healing. Ignorance is a factor that leads to the harm of cultural insensitivity. Cultural insensitivity isn't just a missed opportunity, it's harmful. It can re-traumatize clients, reinforce systemic oppression, or push them out of therapy altogether. Understanding the three dimensions of identity model, also called the tripartite framework of personal identity. Sue and colleagues in Counseling the Culturally Diverse Ninth Ed remind us that identity is not one-dimensional. Instead, it operates on three interlocking levels: the individual, the group, and the universal. Think of it as a set of concentric circles, each layer shaping who we are and how we experience the world. You have the individual level, uniqueness. At this level, we are focusing on what makes each person different from every other human being. Identity includes personal experiences, genetic makeup, personality traits, and individual life history. Example: two African American women may share group identity markers, but differ in religion, hobbies, or temperament. The clinical importance. Counselors must avoid stereotyping by remembering that clients are not only their group memberships, they are unique individuals. Then there's the group level, shared social and cultural identity. This layer emphasizes commonalities within groups: race, ethnicity, gender, sexual orientation, socioeconomic status, age, religion, ability status, etc. These categories shape lived experience, access to resources, and exposure to oppression or privilege. Example: an Asian American client may navigate cultural values like filial piety, collectivism, or model minority stereotypes. The clinical takeaway is that therapists must understand how membership in marginalized or dominant groups influences worldviews, mental health, and help-seeking behavior. Consequently, you have the universal level, known as the shared human experience. This is the recognition of what we share with all human beings: biological needs, food, shelter, common life experiences, birth, death, love, loss, and universal psychological processes. Example: regardless of cultural background, all humans seek safety, belonging, and connection. Clinical issue here is that counselors can build rapport by acknowledging common humanity while avoiding the trap of overgeneralizing. We're all the same. How does this impact therapy or counseling? If therapists focus only on the universal, they risk color blindness, ignoring systemic oppression or cultural differences. If they focus only on the group, they risk stereotyping or essentializing clients. If they focus only on the individual, they may overlook how culture, history, and context shape identity. The challenge is to balance all three dimensions: honor the client's uniqueness, recognize the importance of group membership and systemic forces. Remember that we are all connected through shared humanity. Think of the three dimensions as lenses you switch between. 1. Microscope, individual uniqueness. 2. Ward side angle lens, group identity. 3. We will now conclude this week's session. A couple of things. I just want you to think about it over the week, or even better, as you're completing your reflective assignment. Consider what multicultural counseling or therapy means to you. What type of preconceptions do you have about multicultural counseling and therapy? If you were asked to define multicultural counseling therapy, how would you describe it? As you complete the reflective assignments, I'd like to pose a few questions for you to consider. Rather than answering the questions directly, please reflect on them and choose 3 or 4 to incorporate into your reflection paper. So, one thing to consider is whether someone can truly be colorblind to race here in the United States. And with that, what makes seeing and acknowledging differences so difficult? In what ways does a colorblind approach hinder the counseling relationship when you're working with diverse clients? Another thought might be, what are we likely to see as our most significant challenges when we're exploring our own racism, our own sexism, or heterosexism, or classism, or ageism? Do you recognize any prejudices or biases that you may have, and can you name them? I know that was a lot to take in. As you go through the text and watch and read the various case studies, you find yourself delving even deeper into your own level of awareness to understand where you stand as a clinician and as a human being. This week, please ensure that you complete reading Chapter 2 of your textbook. Then please watch the supervision session with David and Scott. After watching the video, please answer the following questions in the assignment. Each question will be worth 25 points. However, please note that there is no right or wrong answer. I would like for you to reflect on what you observed in the video. Areas covered are: 1. Identify the core issues in the video's supervision session. 2. Compare and contrast the experience of the client and the counselor. 3. Was supervision positive, negative, or both? 4. What were your personal reactions and professional takeaways? Now the assignment questions will be more detailed. Remember to use APA formatting and, of course, provide citations when necessary. Let me apologize again for our shaky beginning. Hopefully, I will be back in full swing by our class time next week. Have a great weekend and holiday.